sessions we've had.
Okay.
And 175 doctors, mostly from Bombay, but we've had
Great.
doctors Pune, Bangalore, Hyderabad.
I think this kind of thing is.
Hello and welcome to Health Live at Seniors Today. This is Pradyuman Maheshwari, your host for the Health Webinar Series. And today we are delighted to welcome Dr. Himesh Gandhi. Dr. Gandhi is a senior urologist and the chief of the robotic surgery department at the Ruby Hall Clinic in Pune. Before I welcome him, I'm going to introduce him. Dr. Gandhi, as I mentioned, is a senior urologist. He has made significant contributions in the field of robotic surgery, urolift, rhythm therapy, and in robotic surgery, he's been at the forefront of utilizing advanced robotic systems to perform minimally invasive procedures with enhanced precision and control. His expertise in this area has led to improved patient outcomes, reduced recovery times, and minimized surgical risks. As I mentioned, he works with urolift, which is again a very low invasive procedure for treating benign prostatic hyperplasia, and has helped many patients experience relief from symptoms without the need for more invasive surgery. In the realm of rhythm therapy, which uses steam to reduce prostate tissue and alleviate symptoms of BPH, Dr. Gandhi has been a pioneer in adopting and promoting this effective treatment. We've invited Dr. Gandhi today to speak about care and prevention of prostate concerns and new trends in treatment. As we've all had various sessions on prostate in the past, we've had issues about prostate concerns, prostate cancer, and as per your feedback that we've received from all of you, we've decided to have a session once again on prostate. But we've also invited Dr. Gandhi to speak about new forms of treatment that are available, because at the end of the day, we would we obviously know that patients are looking for less invasive techniques for surgeries, and if that is available, then we must know about it. Over to you, Dr. Gandhi, and welcome to Health Live at Seniors Today.
Sure. Thank you very much. And as from the promo, I could see many of the urologists, few of my colleagues have already attended it and given a nice discussion regarding the urological conditions. And I once again thank all of you for having me here and attending in such large numbers. Without wasting much time, I'll just like to discuss something which is which now as we doctors should be aware of. Like I treat every week 4 or 5 doctors suffering from this condition, prostate cancer. What I would say is that prostate cancer is one of the leading cause of cancer in males in recent times. And if you see the statistics, every year we see at least 40,000-50,000 new males diagnosed with prostate cancer. And if you see the prevalence for 5 years, almost 80,000-90,000 males are suffering from prostate cancer. It is the 8th most common cause of mortality in males right now in India. And it is often neglected. I see my colleague, a few of the doctors coming with a PSA of 25, 30 and then suffering from prostate cancer. So prostate, this month, basically it's called the Prostate Cancer Awareness Month. And I would say the last month, September. And we did our part in bringing up some awareness with the help of few radio campaigns, and maybe having a free checkup for the men suffering from lower urinary tract symptoms. But what are the markers which we should be more concerned with? Now, everybody has to understand that prostate uh, gland, basically the most important function of the prostate gland is in the reproductive age, where we require some trace elements, some minerals, so that the sperm motility is improved and it is able to fertilize an egg. But after 50 years of age, once the reproductive age is crossed, we are not much concerned regarding the reproduction. The incidence of prostate cancer gradually increases. So if we see the statistics wise, now uh, up to age of 80 years, up to 80% will be having some kind of maybe an indolent cancer or a floric cancer inside the prostate. And what are the signs and symptoms? That uh, this is a GlobeCon data, and if you see clearly, the numbers are quite astonishing, and it is the third most common cause of cancer in males. And this malignancy has some risk factors, like if we see in Indian context, then increasing age, like I clearly told that after the age of 50, 60, certainly the incidence is increasing. Ethnicity, we are not much concerned, but we do see a correlation with a strong family history, like brother, father, first degree relatives, and then the relative risk is also very high. So these are the some of the factors which we commonly see in India. I have operated on the father, on the eldest son in the same family. So this is what we clearly see in our practice. Similarly, we have commonly seen with the mothers having breast cancer or the aunts having breast cancer, and the male suffering from prostate cancer. So these BRCA mutations are also there. And simultaneously, a patient having a chronic prostatitis, and definitely they are also at a higher risk of having a prostate cancer. Is there a way to prevention? If prevention normally doesn't work in prostate cancer unless we try to prevent chronic prostatitis. How to do that? Frequent ejaculation is one of the methods to avoid chronic prostatitis. Another important thing is a healthy lifestyle and nutrition. Drug, we are talking here about dutasteride or finasteride. However, the studies have shown that the incidence of high risk and high grade cancer increases if we keep taking dutasteride, finasteride for a longer duration. So, is there a method to prevent it now? So, prevention, uh, 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 obviously, it is not very much proven thing. Supplementation of selenium, vitamin D also has not been able to prevent prostate cancer, but there is a way of early detection, especially with males more than 50 years of age. PSS screening is one of the important things which you should be routinely practicing, because we have to understand that in India, high risk, high grade prostate cancers are very common. And if we miss the cancer at the initial stage of PSS screening, then we directly land up with a patient having a prostate cancer in stage 3. The another important test what we have introduced in Ruby Hall is called PHI test. This prostate health index. It is only available in Ruby Hall and Lal Path Lab, which they send the sample to New Delhi for the checking. So these are the two places where PHI test is routinely done, and it is proved to be a very useful marker where we can differentiate between chronic prostatitis and elevated PSA due to malignancy. So this is a very important test. Again, we have routinely incorporated in our practice. DRE gives you 20 to 30% only information regarding whether there is a prostatic nodule which is hard enough or not, because the anterior part of the prostate cannot be assessed with a digital rectal examination. What are the signs and symptoms? Actually, early symptoms don't exist. Whenever the patient has a stage 4 metastatic disease, then only the symptoms clearly comes out regarding the prostate cancer. When the patient has a localized disease, the symptoms are same as what we get in a common BPH related symptom score. And when there is an advanced disease, then weight loss, weakness, anemia, pathological fractures, bone pain, lymphedema, neurological symptoms, sometimes patient landing up in a paraplegia. These are the common things what we commonly see. So what are the common thing we routinely follow regarding the initial assessment? So we do a DRE, we do a PSA and PHI, and if both are suspicious, we then offer a biopsy. But there is a change in this protocol. We now prefer to do biopsy as a later stage after the MRI is done. So this is the most important thing. DRE, it should not be omitted. 15% of the men will have a cancer which has a PSA less than 4. So DRE is very much important, and PSA and DRE both are complementary. So when we use both of these things, the accuracy increases from 64% to up to 80% with PSA and DRE. Is age is a factor? I clearly told that increasing age increases the risk. So if you see the fact like age related adjusted PSA values, then definitely with increasing age, the baseline PSA value increases. In India, we use a cutoff of 4, and when the patient is more than 65, 70 years of old, we use a cutoff of 6.5. So this is a standard practice in India. Uh, so right now, the protocol what we commonly follow is we rule out the risk factors. We do a PSA test. Once the PSA is more than 4, we do a PHI test, which helps us to understand whether the patient requires MRI and followed by biopsy. So PHI is very much important in Indian context, where large number of PSA elevations are due to chronic prostatitis. You can clearly see as the PHI score increases, the probability of having a prostate cancer also increases. So this is of very much importance, I would say. Then the guidelines are always there, which suppose that initial evaluation, adjusted risk assessment, age is the criteria. Age here means life expectancy. If the patient is going to survive from 15 to 20 years from the current age, then definitely requires a proper evaluation and a definitive treatment care. If the patient is comorbid, frail, and life expectancy is less than 5 years, then a palliative care only is the treatment option to be afforded. MRI has improved now significantly in early detection of prostate cancer. We have a PIRAT scoring where PIRATs 4 and 5 definitely makes us understand whether the patient requires a biopsy or not. And MRI works as like a Google map in targeting the tissue perfectly. And so before we do a transrectal biopsy, we should always do an MRI. So what are the indications of the biopsy? Like I clearly said, the biomarkers, that is PHI score more than 55, and multiparametric MRI showing a PIRAS 4 and 5 lesion. So transrectal biopsy is the most common biopsy, which is we are offering. Another option is a transperineal biopsy, but in Indian scenario, we don't get a recurrent, too many recurrent infection after transrectal biopsy. That is why we don't feel the need of going through a transperineal biopsy, which is quite painful. And transrectal biopsy can be done under local anesthesia. However, transperineal biopsy requires some kind of either spinal anesthesia or a sedation. So these are the different stages of prostate cancer. Stage 1 is mainly in the right lobe. Stage 2, both the lobes are involved. Stage 3, it is breaching the capsule and spreading to the seminal vesicles. And stage 4, it comes out of the prostate, spread to the surrounding organs and the lymph node. This is a Gleason scoring which we commonly use for biopsy grading, where Gleason 4 and 5 are considered to be the high risk factor. Gleason 3 is a low risk factor. And when we come out with a score, we use a primary score, a primary pattern and a secondary pattern to give out a score. PET scan again is very much important in diagnosing prostate cancer and determining the stage of the disease. Sometimes we do a PET scan before the biopsy so that we can localize which lobe of the prostate has a higher uptake, and we can simultaneously do a targeted biopsy, thus decreasing the number of unnecessary biopsy. Prostate is divided something like this, where we have 6 scores from the right side, 6 scores from the left side, and depending on the core positivity, we normally tag which area of the prostate is involved. This is very much important because when we are doing a nose sparing, we should be absolutely sure which side we cannot spare the nose, and which side we can spare the nose. So the management options for prostate cancer are pretty much laid down in the guidelines. We have a localized disease, we have a locally advanced disease, and we have a metastatic disease. When we are localized disease, we normally make it into low risk, intermediate risk, or a high risk. When there is a low risk disease, active surveillance is an option. Active surveillance is a very rare entity seen in Indian scenario because majority of the cancers what we see are high risk disease. Intermediate risk and high risk disease, if the life expectancy is 15 to 20 years, radical prostatectomy is the best option. If the patient is not willing or unfit for the surgery, we can always give a radiation, but has to be combined with a hormonal treatment. When it comes as a locally advanced disease, still the multimodal approach is an option where hormone, surgery, and radiation can be used all to in toto so that we can cure the patient. And when the patient comes in a metastatic disease, then definitely control is the priority, and we can use a multimodal approach again. And depending on the response, we can add the first line treatment, second line treatment, and third line treatment accordingly. So this is the treatment landscape for prostate cancer. Medically, the disease start as a localized disease where surgery and radiation as an option. And once this breach the barrier of a metastatic status, then definitely the cure is out of question, and it's always about the control. So our priority is to catch the disease here with early PSA screening, PHI testing, MRI testing, and a PSMA PET scan testing, and cure the patient in this stage rather than advancing through this graph. Now, the duration from this stage till this stage is somewhere between 8 to 13 years. So, it is a slow disease which will kill you eventually if you don't act at appropriate time. So, the crux is to diagnose early, treat early, and then make you disease free so that we don't advance on the metastatic part of the disease. So, this will be just a brief intro regarding the prostate cancer. And like Dr. Pradyuman discussed, I would be discussing some minimally invasive surgical options for managing BPH. So in that, we have something what we call as a resume therapy. Resume therapy is something which we are routinely using. I hope the screen is visible, right?
It's not visible. Only yeah,
Now?
now it's available. Yes, now
Yeah.
seen.
Yeah, so this is a resume therapy. We it forms a part of what we call as a minimally invasive surgical treatment option for prostate for managing the BPH. And how does it work? Is this is a machine where a normal distilled water syringe is placed, approximately 20 cc, and this is the gun which is useful for delivering steam inside the prostate. So how does it work? I'll just show you the video. So this is resume. If you want to see the real time disappearance of the adenoma, so this is a median lobe which is present inside the cystoscopy. and this is blocking the bladder mouth. So once the resume is done, this is the image where what we see. So this is normally done after 6 weeks of the treatment, and you can clearly see. So this is the urethra we are going, and this is the verum montanum. This is the small adenoma which was visible, and once you go inside, the entire blocking adenoma is disappeared. So this is the advantage of resume, where we don't cut anything, and simultaneously we get the same result what we were supposed to get with the help of laser or a normal conventional TURP. So this is the advantage of resume. So all kind of patients who are frail patients who cannot undergo proper surgery and the spinal anesthesia, or who want to preserve the sexual function, ejaculation, erection, then this is one of the treatment options which are easily available at our center. Another important thing, what we are doing is something we call as a Urolift. So Urolift is another technology which we are commonly practicing at our center. And how does it work? I'll just show you the. My screen is visible, right? Hello.
Yes, it's visible.
Yeah. So this is Urolift. So how we do it? So basically, BPH, we already know that there is a benign enlargement of the prostate gland, blocking the urine outflow. Since last decade, we have been using TURP and laser enucleation for management of removal of the prostatic tissue. But they have complications like bleeding, then sometimes urinary incontinence, infection, prolonged hematuria, and sometimes continuous burning sensation in the urine. So to overcome all this, we always require something which will replace BPH surgeries like TURP and laser with a less morbid procedure and with an equal efficacy. Because once the patient reaches this stage, clearly the medicines have stopped working and patients require some kind of intervention. So we have something we call it as a Urolift. It is basically a prostatic urethral lift where the prostate is lifted like a curtain. How does it work? We have a gun which has a preloaded stapler. So this is basically having a nitinol capsular tab and a stainless steel a small piece. So this is the implant what we normally use. How it is done? Again, transurethral. This gun is inserted under vision. There is a needle coming and implanting the stapler and delivering the staplers.
Sorry,
So
doctor. Sorry. This screen is not moving.
is it?
It's a yeah. It's a fixed. It's a this.
Just a minute. Huh?
It's the same. It has not changed.
Now,
It hasn't. No.
wait. I'll just stop and reshare. Now is it visible?
Yes. Now it is. Yes.
Yeah. So this is the gun. I'll just show you. This is the gun what we use for the Urolift. So how it is done? It is done transurethral. This gun is inserted under vision with the help of the telescope attached to the gun, and the needle is puncturing the prostate and delivering the implant. So to put it in context, this is something which is happening where initially before the procedure, the prostate is occluded. Then we do transurethral. We deploy the needle. The needle delivers the stapler, and then the another end of the stapler is attached to the inner part of the prostate. So with this, we are able to open up the urethral plate of the prostate, which is very much important for passing urine. Now, the biggest advantage of this technique is that with few clips, we are able to open up the prostatic channel without compromising the sexual function, the ejaculation, and this is the benefit of Urolift. So if we see something this is happening, this is the fire. You can clearly see the stapler is implanted and the urethra is open. This is again on the other side where the stapler is implanted. You can see the stapler and the urethra is open. So this is the procedure what we do, and this is the prostate before the surgery. This is after the surgery. If you see the urine flow rate, this was before the surgery and this is after the surgery. Now the beauty of this is it fills the gap between the medical options and the more invasive laser and the TURP option. So this is the reason why this MIST has been now coming up in a big way. In fact, I am the proctor for teaching the Urolift across India, and what we have seen is tremendous results in all of our doctor colleagues, because we don't need to cut any of the prosthetic tissue. We have to just apply the clips, and the results are clearly evident within for 24 hours. So there is no need for long-term catheter. Patient comes in, we do the procedure. Next day morning, we remove the catheter. The flow improves immediately. Now, some people do ask, what is the long-term benefit of these implants? Now, what happens is, once we place the stapler, it induces a cell cycle death inside the prosthetic tissue. It means that the body uh, innate immunity take care of the dead prostate cells, because there is a pressure necrosis happening at the level of the staples. So that induces a kind of a cell cycle dependent death, and the T cells then gradually come into the picture, and they start, and the natural killer cells and the T cells, they start the apoptosis process inside the prostate, and then the body immune system gradually resolve all the prostatic tissue. So this is the benefit. So when we see a long-term result over 8 to 10 years, the clips still remain there in situ, and it doesn't cause any long-term problem to the patient. The only side effect which the patient normally experience for 1 to 3 days is maybe because some occasional blood in urine, maybe a increased frequency because of the intervention done inside the urethra. Burning is also due to some intervention. Mild pelvic pain, which normally settles in 1 to 3 days, and occasional urgency. All these things resolve within a week's time. Now, Urolift has proven to check all the boxes when it comes to symptom relief, minimal complication, and convenience, both for the patient and the doctor, as it can be performed as an off-it procedure. So, when we see the advantages, it's a rapid relief for the chronic BPH symptoms, no erectile dysfunction, no retrograde ejaculation, no incontinence because there is no cutting involved, a daycare procedure, and good durability with a less retreatment rate. So with this, I would like to stop my presentation, and we will be open for the question and answer session.
Thank you very much, Doctor, for a very detailed presentation. Tell me, first of all, I want to ask you a few general questions. One is that, given your, experience, do you find that the number of patients complaining of prostate has increased over the last few years, or is it given lifestyle changes and the like?
So we put it in a different way. Now, with I would say last 7-8 years, what we have seen, the incidence of prostate cancer has come in a long way, because more PSS testing has come up. Now, symptoms between whether it is a prostatic malignancy or a BPH, normal benign enlargement, symptom-wise, both are same. We cannot differentiate whether it's a BPH or a prostate cancer mainly on the symptom when it is an early stage disease. So, when we say that the number of symptoms has increased, no, over the past 50 years, after the age of 50, invariably some symptoms do happen, and people often neglect it. We get many patients who have a continuous flow, but it is a prolonged flow. They pass urine for 1.5 hours, 2 minutes, 1.5 minutes to 2 minutes. They consider it as a normal thing, unless we make them realize that it is not normal. So many of the times, patients do have symptoms, they don't appreciate it. Many patients come and say that waking up 2 to 3 times at night is normal, which is absolutely not. Maximum one time is acceptable, but 2 to 3 times means every 2 hours he is waking up and is disturbing his sleep, which affects his other day. So these symptoms, sometimes the patient do have, they don't realize it, they consider it as a part of the normal routine or an aging process, which is absolutely wrong. It needs to be evaluated.
Right. Thank you, Doctor. We have a question from Ms. Shamla Ravi, whose question is, what are the contraindications for robotic surgery?
See, there are no, I would say, absolute contraindications, because whatever surgery which can be done through open surgery, abdominal surgery can be done with robotics, unless a patient has a poor ejection fraction where the patient cannot take up the load of the intraperitoneal pressure, intraperitoneal abdominal pressure. Patient has bleeding diastasis, where intraoperative bleeding is a very high risk probability. Such patients, do pose a relative contraindication, but obviously there is no absolute contraindication. Surgeon's experience is one of the biggest factor which should be taken into consideration, because now the with the advent of robot in all the hospitals, all the surgeons claim that they are robotic surgeons, but actually you need to see how much experience that surgeon is having and since how long the surgeon is practicing robotic surgery, because all these factors do make a difference when we are concerned about the post-operative recovery of the patient.
Right. That's a question which there's somebody who's asked, as well as I think it's important that we state as to how do you know that of the proficiency level of a doctor in robotic surgery, because the technology itself is not very old. So what would you think is a requirement as far as proficiency levels, or what should a person look at when
Yeah,
one is assessing?
correct. So now this is I would like to share one important thing. Those who are trained robotic surgeons, like I got my training from Singapore, few are just getting trained. So there is a app by Intuitive, the robotic company. So it gives you a proficiency level of that surgeon. Okay, since how long he has practiced, how many cases he has done. So if you really want to test the proficiency level of a surgeon, you can easily ask for the number of surgeries done by that surgeon. So if you see, if it's visible, so this is a app that is installed on each and every surgeon robotic surgeon's phone. So if you can ask them, this data will not lie. Yeah, how many surgeons a surgery that guy has done, you understand?
But
Because
doctor, isn't it a little impolite? For instance, if say I were to come to you and ask
see,
you, doctor, give me
yeah,
your
yeah,
score.
yeah. So here the difference comes in, because when I was practicing in Singapore and my colleagues in US, it is not at all impolite, because if I want to hand over my body to you, it is my right to ask about your expertise, whether you are competent enough to deal with this kind of case or not. You understand? Because each surgeon has a learning curve. So and nobody is going to tell you that I have done 5 cases, 10 cases, unless you ask for it. So there is only one way where nobody can bluff, is showing their own statistics, and that is updated on case to case daily basis. So not a single case is missed in this kind of thing.
So
So
what,
this is,
according to you, should is a right score, or above a certain score is you are in safe hands? What would that be?
yes. So now scoring system has not been developed yet for robotic surgeons. How we assess, because I myself is a proctor for robotic surgery. I i have i go across country to start new robotic surgery programs. So for us, at least 25 to 30 cases in that particular disease is considered to be a satisfactory score, where a doctor is allowed to do the surgery independently. So till that 30 cases, he has to be observed by senior surgeon, and he has to do cases under that surgeon. So this kind of some statistics we have made compulsory before we certified that this surgeon is allowed to do a case freely. Now, when it comes to the patient part, so patient has to understand since how long the robot has been installed in the institute, and how many cases has the institute done so far, before they can uh, simply rely on the doctor's word. What I would put it as.
Uh, Doctor,
So it is very complicated, you understand, but
right.
now everything is available on Google. So you can just cross check how many cases are there, how many views are there on robotic surgeries regarding that doctor, and then the patient has to obviously make a call.
Right, doctor. We have a few more questions that have come in, quite a few questions actually. Uh, uh, can prostate cancer be, is it fully curable? We have a
Yes.
question from Shada Parvare.
So up to stage 3, it is up to 95% curable. Up to stage 3, I showed the staging of the prostate cancer. So
Right.
up to stage 3, stage 1 and 2 are 100% curable. Stage 3 is 95% curable. When it comes to stage 4, it is 30% curable.
Right.
So
Um,
a proper uro-oncologist can definitely guide you regarding how it can be cured.
Thank you. To those of you who have missed, doctor's presentation, and if you'd like to watch it again, the edited video will be up on the Seniors Today website on Monday evening, along with the takeaways. So you can look at that, even if you've not made notes, etc. We have a question uh, from Saroj, who asks, which hospital in Mumbai caters to resume?
That's a very difficult question because I am not aware yet which hospital has purchased the machine. But I'm sure that if you can manage to come to Ruby Hall, definitely we can help you because we have the machine installed and we have been regularly doing since last 1 month now.
So you need to do the trek to Pune for that. We have a question
It's a
by
nice,
Mr.
pleasant drive.
Right. I can vouch for that. We have a question from Mr. P. Satyanarayan, who says his PSA was 11.84 and then came down to 5.4, tested during March 22. Um, he wants advice. He's not asked a question. He says, but continuous burning pain is there. What precaution is needed? His present age is 76.
So what I would suggest you can get a PHI test done. So that will rule out whether it's a chronic prostatitis or sometimes infection. Malignancy also presents as urinary tract infection and causes kind of a masking effect. So best thing for you will be do a PHI, see what is the value, and if there is a continuous burning pain, you can do an MRI of the prostate to rule out whether there is some chronic prostatitis or not.
Right. Thank you. We have a question from Mr. Anil Singh. Does high PSA mean that I have prostate cancer? My real uncle had prostate cancer, but not my parents. Do I have more risk of prostate cancer? Is it hereditary? Is it
Yeah,
genetic?
yeah. So I think I already answered that
Right.
thing.
Yes.
So definitely, if your blood relative has some prostate issues, malignancy, even though your father didn't have, it doesn't mean that the gene is not traveling. It is traveling. So definitely get yourself thoroughly assessed. PSA, if it's high, do a PHI. If PHI again suspect that there is a possibility, get an MRI done and rule out all the possibility for having prostate cancer.
Right. Thank you. We have a question from Mr. Vinay Srivastav, who says, Doctor, I drink water every time I get up to urinate at night so that my body does not get dehydrated. Please tell me if there's any problem in doing this.
So the now you have to understand, just compare yourself when you were maybe in 35, 40 years of age. Now we were used to get hardly once at night to pass urine. If you are getting maybe 2, 3 times, then you need a assessment. It is nothing to do with getting dehydrated. It is see, now the main context of doing all this exercise is to save the bladder. Now, just forget about the prostate. The entire discussion is now moving towards saving the bladder. Bladder is like heart. If the heart gets affected, the body circulation system gets affected. Similarly, if the bladder gets affected, the peeing mechanism becomes difficult. So it is the concept is changing towards saving the bladder. Many urologists, I shouldn't be saying this, but many of the doctors, urologists, they keep giving medicines for 5 years, 6 years down the lane, Urimax, Silofast, or in that bargain, the bladder really gets compromised. And then if the bladder gets damaged, then there is nothing in the world which can replace a damaged bladder. So prostate is just a mountain through which we have to make a passage sufficient enough to for the bladder to make sure that the urine is passed on freely. If you keep prolonging your problem, avoid prostate surgery, and just get your bladder compromised, then no medicine in the world will be able to cure that compromised bladder.
Thank you very much, Dr. Himesh Gandhi, for all your time today. We have a few questions, but they are mostly repeat. So all of you here, I'm sorry we've not been able to take all the questions. We are running out of time, but do watch the presentation, and all the questions that you would have wanted to ask will be answered in that. And thank you very much once again, Dr. Gandhi, for being here, and to the team at Ruby Hall, Dr. Sharma, to having facilitated this. It's indeed good to know that even tier 2 cities like Pune have advanced level medical equipment and medical technology that have come in. And I think the solution to for solving India's various medical issues is that the best facilities are available beyond beyond the four metros, and it's good to have doctors like yourself who provide that confidence. Thank you very much, Dr. Himesh Gandhi, for being here. I have a special announcement to make. Next week, because it is Dussehra, we are not having a session. That is on October 12th. We are not having a session. So I know you'll miss being here, but it's a festival day, and we've had our experience, and we've had feedback telling us that we don't want to discuss medical issues on a festival day. So we don't have a session next Saturday. That is October 12th. Happy Dussehra, happy Vijayadashmi, happy Durga Puja, Navratri, and in whatever way you celebrate it. And we will meet you the Saturday after that. That is October 19th. The time is the same, 5 p.m. And enjoy yourself. Take care of yourself. Have a great festival season. Enjoy responsibly is what I would say, and have a healthy time. Thank you once again, Dr. Himesh Gandhi, for being here.
Thank you, sir.
See you
And
all.
thank you, seniors, today for this
See you all
opportunity.
on